posterior leaflet motion and leaflet prolapse. So these are the Doppler findings in acute rheumatic fever, where a pathological microregurgitation is seen in at least 2 views with a jet length of more than 2 centimeters in at least 1 view, a peak velocity more than 3 meters per second, and a pan-systolic jet in at least 1 view. And pathological aortic regurgitation, where the jet is seen at least in 2 views with a jet length of more than 1 centimeter and peak velocity more than 3 meters per second, and a pan-systolic jet in at least 1 view. So based on these, after a lot of echocardiographic screening and taking echocardiography into the clinical practice and more of screening, we know like we were previously dealing only with clinical rheumatic heart disease, where you have clinical signs and symptoms suggesting of a pathological heart murmur and you diagnose a heart disease. Now after this echocardiographic screening, echocardiography has come into the place of diagnosis. We have detected a lot of subclinical rheumatic heart disease, where there is no clinical signs and symptoms of heart murmur, but in spite of it we detect a lot of rheumatic heart disease. And when you make echocardiographic screening in a population based manner, then you may detect a lot of alien cases which does not fit into these two criteria. So once you detect a case, the next thing is the secondary prophylaxis. So secondary prophylaxis, as you know, when there is acute rheumatic fever without carditis, it is 5 years from the last episode or 21 years, whichever is longer. When there is carditis but no residual heart disease, it is 21 years of age or 10 years from the last episode of acute rheumatic fever, whichever is longer. And if it is a carditis with residual heart disease, it is until 40 years of age or 10 years from the last acute rheumatic fever episode. And sometimes you may need a lifetime prophylaxis also, especially in people who have undergone a heart disease surgeries. And this secondary prophylaxis, benzathine penicillin is the effective prophylaxis compared to oral penicillin based on many studies. But what is the common problems we face is procurement of this benzathine penicillin and injections which is given every 3 to 4 weeks. It's a big problem in complaints of the patient and the pain associated with benzathine penicillin. These are the problems which we face in regular practice when you come to secondary prophylaxis. So secondary prophylaxis, definitely it is the cornerstone in preventing rheumatic heart disease, and recurrent rheumatic fever becomes less common after 25 years of age, and it is very rare after 30 years of age. So screening at initial stages and early institution of secondary prophylaxis will help in preventing the rheumatic heart disease. And we can say if you treat symptomatic streptococcal infections, we can prevent rheumatic fever, but it is not the case because of over the counter medications, like many of the sore throat has been treated improperly, and sometimes there may be a latent group A streptococcal infection which can also trigger a acute rheumatic fever. So another two entities, which is when you don't have a classical criteria of Jones criteria which doesn't fit for the patient, we can have a two diagnosis of possible rheumatic fever and a probable acute rheumatic fever. So in these cases you need not fit into a diagnosis of Jones criteria, but still based on your clinical knowledge you can go ahead and treat the patient as an acute rheumatic fever. In these cases you have to reassess the patient after 12 months. If the patient still have a normal echo after 12 months, then based on the clinical things you can stop the prophylaxis or continue with the prophylaxis. So for conclusion, early detection of acute rheumatic fever, subclinical and latent carditis with extensive echocardiographic screening and adequate secondary chemoprophylaxis will be the only way to reduce the disease burden in endemic regions, and this will be the way forward also. Echocardiogram plays a major role in early detection of severe disease, and early intervention helps in providing better outcomes. And we have to change our modalities from clinical thing to invasive like echocardiographic, and also we have to think about having a genetic based screening modalities which will be the future of acute rheumatic fever prevention. And there should be a revision in the guidelines which should be focused on avoiding overdiagnosis in low risk population, and also prevention and early detection of rheumatic heart disease in the moderate to high intensity populations. Thank you.